At the conclusion of this presentation, participants should be able to define embryology and describe the stages of embryo development from fertilization to implantation, identify methods for monitoring first trimester pregnancies conceived after infertility treatment, describe the impact of complications following infertility treatment as it relates to the risk of multiple gestations, ectopic pregnancy, and early pregnancy loss, and identify appropriate patient education and anticipatory guidance tools. Early pregnancy is often an exciting yet anxiety-provoking time for couples, particularly for those who have invested time, emotion, and money in infertility treatment. Early diagnosis and appropriate assessment and management of the pregnancy are important in identifying potential difficulties, such as a multiple gestation or a pregnancy loss, and in promoting a healthy pregnancy. A multidisciplinary team of healthcare providers plays an important role in providing optimal care and patient education. The gestational calendar begins on the first day of the menstrual period of the conception cycle. Ovulation generally occurs at the end of gestational week 2, followed by fertilization and implantation. The first Miss Menses is at the end of gestational week 4. A woman who has a positive pregnancy test with a missed period is in her 4th gestational week, although the actual pregnancy is only 2 weeks into development. It should be noted that this may not be applicable for ovarian stimulation cycles with long follicular phases induced by gonadotropins or downregulation, and thus gestational dating may be more accurately based on the date of ovulation or embryo transfer. The pregnancy due date is typically calculated using a gestation of 280 days from the last menstrual period. Pregnancy is detected by measurement of serum HCG. By the time of the expected but missed menses, serum beta-HCG levels are approximately 100 international units per liter. This level is variable and may be influenced by many factors, including multiple gestation. Maximum levels of 100,000 international units per liter are reached at 8 to 10 weeks gestation. Levels decrease and remain steady at 10,000 to 20,000 international units per liter from around 18 to 20 weeks to term. HCG is produced by the developing embryo before implantation. Various methods are used to measure serum HCG levels, and these tests may detect levels as low as 25 international units per liter. Home urinary HCG tests are variable and detect HCG levels of 25 to 100 international units per liter, and thus may be falsely negative when used in the 4th and 5th gestational weeks, when levels may be below the detectable range. To evaluate early pregnancy, the first HCG level is commonly drawn at the time of an expected but missed menses at about 4 to 5 weeks gestation. Although a higher initial level may predict a better outcome, higher levels produced by a multiple gestation can affect the interpretation of the initial result. A second measurement can be performed 48 hours later. A 50% rise usually indicates a normal pregnancy, but significant errors in measurement do occur because the levels are so high. Failure to rise at least 66% may prompt further evaluation to rule out an ectopic or non-viable pregnancy. The timing of the first HCG measurement may be modified based on the mode of conception, such as spontaneous, intrauterine insemination, or in vitro fertilization. Pregnancy status is described as biochemical, clinical, or ongoing. With a biochemical pregnancy, a pregnancy was detected by presence of serum or urinary HCG, but miscarriage occurred prior to ultrasound confirmation. With such losses, beta-specific HCG levels are lower than normal and either do not rise or decrease. A blighted ovum is a gestational sac with no embryonic presence identified on ultrasound examination. Typically, HCG levels eventually decrease and serum progesterone or estradiol levels are lower than normal. A clinical pregnancy is diagnosed once a pregnancy is confirmed by ultrasound. HCG levels rise appropriately as noted in the previous chart. An ongoing pregnancy is a current, viable pregnancy as shown in the image here. Let's begin with some basic information about embryology, which is the science and study of the formation, early growth, and development of living organisms. In the field of infertility, embryology focuses on human development from the fertilized egg to implantation and through early embryo development. Following penetration by a single sperm, the fertilized oocyte or zygote is transported through the fallopian tube by the movement of the cilia of the tubal epithelium and the contractions of its muscular layer. Progressively developing and dividing, the embryo enters the uterine cavity at the end of the 6th day. Approximately 7 days after fertilization, the blastocyst bursts from the zona pellucida, which is called hatching, and implants in the wall of the uterus. The inner cell mass becomes the fetus, and the outer cells become the placenta and fetal membranes. The presence of HCG from the blastocyst stimulates the corpus luteum of the maternal ovary to secrete progesterone. In the following discussion of embryonic and fetal development, the timeline indicates developmental week and does not refer to gestational age. To correlate with gestational age, adjust by adding 2 weeks to account for time from the last menstrual period to fertilization. Some of the major hallmarks of embryologic development are noted here. Developmental weeks 3 through 8 represent the period of organ development, or organogenesis, which is critical for normal development and is the time when most structural birth defects occur. The neural tube closes during developmental week 4, and at week 5, limb and facial development begin, and the embryo appears tightly C-shaped, as shown here. In developmental week 6, there is early formation of fingers and toes, brain vesicles are prominent, the external ear forms, and umbilical herniation begins. In the 7th developmental week, pigmentation of the retina is seen, fingers and toes separate, and the upper lip and nipples form, as illustrated in the image here. The embryo is called a fetus beginning with the 8th gestational week. Women who become pregnant following infertility treatment typically have many questions about their care and concerns about the well-being of their pregnancy. Accurate information and anticipatory guidance about their activity, diet, and safety, as well as support of their psychological needs, are important in the early weeks before being referred for obstetrical care. Many women will require luteal phase support for an infertility treatment-conceived pregnancy. The corpus luteum, which is the site from where the egg ovulated, is the primary source of progesterone until approximately 10 weeks gestation. The placenta begins to produce steroids between 7 and 9 weeks gestation until it takes over completely. Corpus luteal cells are disrupted during oocyte retrieval in women who use IVF to conceive. In addition, certain medications taken during an assisted reproductive technology cycle, such as a GnRH agonist or antagonist, which is used to prevent a premature luteinizing hormone surge and ovulation, continues to suppress endogenous LH production after discontinuation of medicine. These low levels of LH may not be sufficient to stimulate the corpus luteum. Thus, pregnancies conceived with ART require support with daily progesterone supplementation until approximately 10 weeks gestation. Supplementation is continued until placental production is expected. Because recipients of oocyte donation and those undergoing frozen embryo transfer cycles do not have a corpus luteum, they may require extended supplementation of both progesterone and estrogen until the placenta is fully competent. Dietary recommendations for pregnancy include the following. An additional 300 calories over a woman's current intake is usually recommended for pregnant women with normal pre-pregnancy body mass index and more for women with a multiple gestation. Women should take a daily multivitamin with at least 30 milligrams ferrous iron and 0.4 milligrams of folic acid. Daily vitamin and mineral intake more than twice the recommended daily dietary allowance should be avoided, as it could be toxic. If a woman has a history of having a child affected by a neural tube defect, or if the male partner has a neural tube defect, the woman should take 4 milligrams folic acid daily for at least 1 month prior to conception and during early pregnancy. 7 or more servings per day of fruits and vegetables and 6 to 9 servings of whole grains per day are recommended. At least 4 servings per day of dairy products provide calcium, protein, and vitamin D. The recommended intake of calcium is 1,000 milligrams per day, the same as for non-pregnant women. 60 grams per day, 2 to 3 servings of protein are recommended. Fats should make up 20 to 35% of the daily caloric intake, with limited saturated and trans fats. There are certain dietary restrictions in pregnancy that can minimize risks to the developing fetus. Fish is an excellent source of protein and healthy fats, but because most fish and shellfish contain trace amounts of methylmercury, which is neurotoxic to the fetus, the U.S. Environmental Protection Agency and Food and Drug Administration recommend consumption of no more than 12 ounces of fish and shellfish that are lower in methylmercury per week. Pregnant women should consume no more than 2 servings of canned tuna per week and no more than 6 ounces of albacore or white tuna. Fish and seafood with low levels of mercury include shrimp, salmon, pollock, and catfish. Fish with high levels of mercury, which should be avoided, include swordfish, shark, tilefish, and king mackerel. Because of their suppressed immune systems, pregnant women are at increased risk for infection with Listeria monocytogenes, a bacterium found in certain foods. Infection can result in miscarriage and a wide range of fetal and infant health problems. Listeria is killed by pasteurization and cooking. However, in certain ready-to-eat foods, such as hot dogs and deli meats, contamination may occur after cooking but before packaging. The Centers for Disease Control and Prevention and the Food and Drug Administration recommend that pregnant women avoid the following foods: hot dogs and luncheon meats, unless reheated until steaming hot, soft cheeses such as feta, brie, and camembert, blue vein cheeses, and Mexican soft cheeses such as queso blanco, queso fresco, or panela, unless made with pasteurized milk, refrigerated pâtés or meat spreads, and refrigerated smoked seafood such as Nova style, unless in a cooked dish such as a casserole. Women should be encouraged to drink at least 8 8-ounce glasses of water or other fluids each day, and to limit caffeine and avoid all forms of alcohol. According to the guidelines issued in 2009 by the Institute of Medicine, healthy American women at normal weight for their height, a BMI of 18.5 to 24.9, should gain 25 to 35 pounds during a singleton pregnancy. Underweight women with BMI less than 18.5 should gain more, 28 to 40 pounds, and overweight women, BMI of 25 to 29.9, should gain less, 15 to 25 pounds. Obese women, BMI greater than 30, should limit gain to 11 to 20 pounds. Calculations for rate assume a weight gain of 1/2 to 2.0 kilograms or 1.1 to 4.4 pounds during the first trimester. Women pregnant with twins in the normal BMI category should aim to gain 37 to 54 pounds, overweight women 31 to 50 pounds, and obese women 25 to 42 pounds. Women carrying high-order multiples likely will need even more weight gain with appropriate nutritional interventions. Early pregnancy nutrition may be hampered by nausea and vomiting of pregnancy, which is frequently referred to as morning sickness. However, symptoms may occur at any time of the day or night. It is experienced by a majority of women by 9 weeks gestation. Frequent small carbohydrate meals may help, along with avoidance of greasy or spicy foods. Fresh ginger root, vitamin B6, and motion sickness bands appear to be effective in relieving symptoms. Other treatments, such as acupuncture, have not been shown to be more effective than placebo. Most cases of nausea and vomiting of pregnancy can be managed without medications and resolved by about 20 weeks. In some women, hyperemesis gravidarum, which is extreme, persistent nausea and vomiting during pregnancy, can cause dehydration and electrolyte imbalance and become serious, requiring close medical attention. Hyperemesis gravidarum tends to be more common in younger women and in multiple gestations. Nearly all drugs, including over-the-counter medications, cross the placenta and have the potential to affect the developing fetus. When possible, It is best to avoid all medications, including over-the-counter and prescription drugs, in the first trimester when organogenesis is occurring. Examples of known teratogens are retinoids, phenytoin, and warfarin. Generally, acetaminophen may be used for pain relief, but non-steroidal anti-inflammatory drugs, such as ibuprofen and aspirin, should be avoided, especially in the third trimester, because of constriction of the fetal ductus arteriosus and risk for persistent pulmonary hypertension in the newborn. For constipation, dietary fibers such as psyllium or surface-active agents such as docusate can be used. Calcium carbonate may be used as an antacid. Pregnant women should not smoke and also should avoid secondhand smoke. Smoking in pregnancy is associated with premature rupture of membranes, placental abruption, and placenta previa, as well as preterm birth and low birth weight infants. An excellent source of information about teratogens is the Organization of Teratology Information Specialists at the website shown here. Certain medications for chronic conditions such as hypertension, epilepsy, bipolar disorder, or antiphospholipid syndrome should not be abruptly discontinued. If a safer alternative is available, the medication should be changed. Metformin often is used to treat obese anovulatory women with polycystic ovary syndrome and insulin resistance. It is not clear if the risk of first trimester miscarriage for these women is decreased with the continued use of metformin during pregnancy. Metformin is designated as a pregnancy category B drug by the FDA, meaning that although animal studies have not shown a risk to the fetus, there are no adequate and well-controlled studies in pregnant women. Although there does not appear to be an increased rate of birth defects or complications at birth with metformin use in pregnancy, each case should be individually reviewed. In the absence of medical or obstetrical complications, the American College of Obstetricians and Gynecologists recommends 30 minutes of daily moderate intensity exercise, such as swimming, brisk walking, or prenatal exercise classes. Activities that carry a high risk of falling or trauma should be avoided, as well as heavy lifting. Scuba diving is not safe in pregnancy, as the fetus is at increased risk for decompression sickness. Women with ovarian hyperstimulation syndrome may need restricted activity until it resolves. Both the lap and shoulder belt should be used in car travel, with the lap belt placed low across the hip bones. Occasional air travel is considered safe in pregnancy up until 36 weeks gestation. Women should be advised to use a seatbelt while seated, fastened at the hip bones, and periodically move lower extremities and ambulate. Hydration and support stockings may also be used to minimize any risk of venous thrombosis. Cramping is commonly experienced with intercourse. Intercourse may be discouraged if there is preterm cervical dilation, placenta previa, leaking of amniotic fluid, or bleeding. Let's talk about some of the complications that may occur in early pregnancy. Some studies have shown that singleton conceptions with ART treatments, such as IVF and intracytoplasmic sperm injection, have slightly higher rates of adverse pregnancy outcomes. A 2007 report from the National Institute of Child Health and Human Development noted that although the vast majority of singleton ART pregnancies are uncomplicated, the rates for nearly all perinatal and maternal complications and certain genetic risks are higher than for spontaneously conceived singleton gestations. It is not clear whether these risks are related to the treatment or to an underlying reproductive pathology. The report noted that ART patients tend to be older than average, and age is an independent contributory risk factor for many complications. This was also observed in another report from the National Center for Chronic Disease Prevention and Health Promotion of the Centers for Disease Control, which noted that women who conceive with ART are more likely than women who do not to enter pregnancy with a chronic condition and develop complications during pregnancy and labor and delivery. The report also observed that infants born after ART are at increased risk for adverse health outcomes. Recent reports indicate that infants conceived with ART have slightly lower birth weights and may have a slightly higher incidence of birth defects than spontaneously conceived infants. Maternal, perinatal, and neonatal complications are common with multiple births, but ART treatment itself was not found to be a risk factor for adverse perinatal outcome in twin deliveries, according to a population-based study. The study found that risks for several outcomes, such as very low birth weight and infant death, were somewhat lower among ART twin deliveries. However, it is important to remember that the risk of adverse outcomes among twin births is substantially higher than those of singleton births. Multiple birth rates vary according to mode of conception. About 60% of twins and 20% of high-order multiples are conceived spontaneously. Infertility therapies and ART treatments account for the remaining percentages. The rate of twins with spontaneous conception is 1.25%, with clomiphene citrate 5 to 8%, and with gonadotropin stimulation 15 to 20%. Some studies indicate that aromatase inhibitors may have a lower rate of multiple pregnancies. With IVF, the twinning rate is 15 to 33% and varies inversely with maternal age and directly with the number of embryos transferred. High-order multiples, triplets or more, make up less than 5% of all multiple births, but the vast majority are a result of infertility therapies, with about 20% occurring spontaneously. Less than 2% of IVF cycles result in high-order multiples. In turn, approximately 40% of high-order multiples are related to ovulation-inducing drugs without ART, and about 40% result from ART. The data shown in the chart are from ART clinic reports from ASRM's Society for Assisted Reproductive Technology and indicate the rates for twin and high-order multiples by maternal age. The major source of perinatal morbidity and mortality in twin gestations is spontaneous preterm birth. Nearly two-thirds of twins and the vast majority of triplets or more are born before 37 weeks of gestation. For multiples, there is no effective therapy for preventing preterm birth. Multiple pregnancies also have higher rates of complications for both mother and babies, including high blood pressure and gestational diabetes. Monozygotic multiples, particularly those sharing a placenta, are at higher risk for complications compared to dizygotic twins. In addition to twin-to-twin transfusion syndrome, monozygotic multiples have a higher incidence of birth defects. The infant death rate in twins is 5 times higher than that of singletons. Because of the risk of complications, referral of high-order multiple gestations to a maternal fetal medicine specialist is often recommended. Strategies for preventing high-order multiple gestations in ovarian stimulation cycles include careful monitoring of estradiol levels and follicle development, with cycle cancellation or conversion to an IVF cycle with cryopreservation of excess embryos. ASRM has established guidelines for embryo transfer, which are addressed in more detail in another module of this series. In appropriately selected patients, single embryo transfer appears to be superior to double embryo transfer when taking into account the number of deliveries with at least one live-born child, incremental cost-effectiveness ratio, and maternal and pediatric complications. Education regarding the risks of multiple pregnancy leads to increased acceptance of elective single embryo transfer. Multifetal reduction is the termination of one or more fetuses in a multiple gestation. Since the risk of complications is proportional to the number of fetuses in utero, the goal of multifetal pregnancy reduction is to reduce the risk of adverse outcomes in survivors of high-order multiple pregnancies by decreasing the number of fetuses. Multifetal reduction is typically performed from 10 to 13 weeks gestation. Under ultrasound guidance, potassium chloride or urea is injected into the fetal thorax. Asystole is confirmed by ultrasound. A reduction is considered selective when a specific fetus or fetuses are selected because of prior prenatal diagnosis indicating an anomaly or genetic defect. There are, however, risks involved in the procedure, including the chance that all fetuses may be lost, which increases with higher starting numbers of fetuses. The procedure also does not completely eliminate the risks associated with multiple pregnancy. Generally, higher starting numbers before reduction are associated with poorer perinatal and infant outcomes in the remaining fetuses. Reduction may also present an ethical dilemma for some clinicians and patients and may have adverse psychological consequences. It is inappropriate to transfer excessive numbers of embryos and then routinely use multifetal reduction to limit the number of fetuses in a pregnancy. The rate of spontaneous miscarriage in the general population is approximately 16%, according to data from the Centers for Disease Control and Prevention. Patients undergoing a fresh cycle of IVF do not appear to have a higher rate of miscarriage compared to age-matched women in the general population. Cycles with cryopreserved and thawed embryos possibly have a slightly higher rate of miscarriage than the general population. Age is the single most important factor for predicting the likelihood of miscarriage. In the case of IVF, the maternal genetic age is the most important determinant of miscarriage rate. The diagnosis of miscarriage can be made in several ways. A woman may experience symptoms suggestive of a miscarriage, including bleeding, spotting, and cramping, or may pass gestational tissue vaginally. Declining levels of HCG in the first trimester are also suggestive of a miscarriage. Finally, an ultrasound that shows no evidence of a fetal heartbeat after 6 to 7 weeks gestation strongly suggests a miscarriage. Infertility treatment is also associated with an increased risk of ectopic and heterotopic pregnancies. Ectopic implantations typically occur in the fallopian tube, but may be in any extrauterine location. Heterotopic pregnancy refers to a multiple gestation with both an intrauterine implantation and an abnormal implantation. Diagnosis of an ectopic pregnancy requires consideration of a patient's history, including her gestational age, findings on pelvic ultrasound, and trends in HCG levels. As noted earlier, abnormal HCG levels can indicate an ectopic or abnormal intrauterine pregnancy and should be followed approximately every 48 hours to assist in clinical diagnosis. A pelvic ultrasound is an integral part of the ectopic pregnancy evaluation. Due to the detection thresholds of an ultrasound, a normal singleton intrauterine pregnancy may not be confirmed until HCG levels are greater than 2,000 international units per liter. However, it is crucial to consider the possibility of multiple gestation, particularly in patients undergoing infertility treatment. In this circumstance, HCG values may be higher than otherwise expected and still reflect a normal pregnancy. For this reason, it is always critical to factor gestational age into decisions involving evaluation of an early pregnancy. For instance, a normal twin pregnancy may not be visible in the uterus despite the fact that HCG levels exceed 2,000 international units per liter. Shown here is a transvaginal ultrasound scan of a left tubal ectopic triplet pregnancy. The interstitial gestational sac with live embryo and a blighted twin is seen in the left image, and an additional ampullary gestational sac with a live embryo in the image on the right. As a final part of the ectopic pregnancy evaluation, any patient with a suggestive history should be evaluated promptly. A suggestive history would include symptoms of significant, particularly sharp, pelvic pain with or without vaginal bleeding. This applies to infertility patients who have a normal HCG trend but have not had an ultrasound confirming an intrauterine pregnancy, though, as stated earlier, gestational age is an important part of the consideration. Management options depend on how these diagnostic puzzle pieces fit together and patient stability. When an ectopic pregnancy is suspected but not confirmed, management is largely driven by clinical symptoms. In select circumstances, a stable patient can be followed closely to determine more accurately whether she has an ectopic pregnancy. If the HCG trend is markedly abnormal, but there is suspicion this reflects a miscarriage rather than an ectopic pregnancy, consideration of endometrial sampling can allow the clinician to differentiate between a failing intrauterine pregnancy, that is a miscarriage, versus whether an ectopic pregnancy is more likely. That is, no gestational tissue is present when the endometrium is sampled. Methotrexate treatment and surgery generally are reserved for circumstances in which an ectopic pregnancy can be definitively diagnosed or is suspected with high probability. Methotrexate, a chemotherapeutic agent when used at high doses, is injected at low doses. It acts by impairing the rapid cell division seen in tissues like a developing embryo. In certain circumstances, repeated doses of methotrexate are required to adequately treat an ectopic pregnancy, as determined by the trend in HCG levels. Methotrexate will fail in some circumstances, though, especially when HCG levels are particularly high or the ectopic mass is particularly large. Certain women are not candidates for methotrexate therapy, including those with hepatic, hematologic, or renal insufficiency, or with a coexisting intrauterine pregnancy. Surgery can be avoided in most cases, but is always indicated in the circumstance of an acutely unstable patient with a high likelihood of or a confirmed ectopic pregnancy. Women who have failed to respond to methotrexate may also require surgery. In these situations, laparoscopy is nearly always used to perform a salpingectomy or salpingostomy for removal of the ectopic pregnancy. Referral to obstetric care occurs after a viable intrauterine pregnancy has been confirmed by ultrasound, generally in the late first trimester. For some patients, particularly those with a high-order multiple gestation, referral to a maternal fetal medicine specialist may be indicated. Other patients at risk who may benefit from an MFM referral include patients with medical or surgical disorders and healthy women at high risk of pregnancy complications. Once a patient is ready for transfer to obstetric care, the content of what is to be included in records should be discussed with the patient. There may be confidentiality issues related to donor gametes or the use of ART therapy itself. There are multiple resources available for patients, including the ASRM, Resolve, ACOG, and AIUM. Early diagnosis and appropriate assessment and management are important for pregnancies after infertility. Patient education, counseling, and anticipatory guidance are essential. These pregnancies have increased risks for ectopic pregnancy and miscarriage. All multiple gestations, including twins, have substantial maternal, fetal, and perinatal risks. Thank you for participating in this educational activity.